Hello everybody, we've just turned 12 o'clock, so I'm going to make a start. Welcome to this webinar, Living with Multiple Chronic Conditions. It's one of a series. This is the second one. We've had this is about heart failure and chronic kidney disease. We've had one earlier which is available to view if people want to do so. And then we've got two more coming up. One on obesity, fatty liver disease and diabetes on the 24th of April, and another one on the 13th of May about health inequalities. My name is Jane Skinner. I'm a strategic advisor for cardiovascular disease, and I work with Health Innovation North East North Cumbria, and it gives me great pleasure to chair this on behalf of Health Innovation North East North Cumbria and also Health Innovation Yorkshire and Humber. If a few housekeeping rules before we start, can you please make sure that your microphones and videos are turned off during the session so that we don't get any disruption. If you need to take a break, please feel free to do so, drop out and then come back in. The event is being recorded and will be shared. And if you have any questions, can you ask them through the chat facility, please? We'll try and address questions during the event, either by our speakers once they've finished adding to that chat, or by taking questions at the end of the talks. But if we don't manage to do that within the time that we have, we're aiming to finish by 1 o'clock, then we'll follow that up afterwards. Any questions, then Sarah's email's there. Health innovation networks were previously the academic health science networks. I'm going to move on from there. They're a collaboration, and we very much value working with our partners. Next slide. Right, I'm going to move on without further ado and introduce our speakers. Our first speaker is Rani Khatib, who's a senior clinical consultant pharmacist working in Leeds. He's got an extensive background both locally, nationally and internationally, and works both very much within the clinical setting, but also with a significant research interest. So I'm going to hand over straight away to Rani.
Thank you so much, Jane. I'm just going to share my slides. Second. It's coming through. Did it come through?
Yes, we can see yours, Rani.
Yeah, that's fine. Thanks.
Yeah, good. So today is the second webinar of our series of Living with Multiple Chronic Conditions. As Jane has introduced the series, we will be focusing on heart failure and chronic kidney disease, or CKD. So I'm hoping in my session I will explore the interplay between heart failure and CKD, and explore the heart failure a little bit more with its management and CKD, and any of the tips and considerations that we need to be aware of when managing these conditions. So heart failure is a major public health problem worldwide, not just in the UK. The prevalence is expected to increase to probably about 46% by 2030. 5-year mortality rate 50%, getting better with all the multiple therapies, but still a challenge. Mortality risk is similar to some of the common cancers, both in men and women. And what is important is that where previously we're very much focused on heart failure with reduced ejection fraction, there is an acknowledgement that the other 50% of heart failure, which is heart failure with preserved ejection fraction, is also quite prevalent, and we have more developments in this territory, and therefore more guidelines and therapies have been recommended to manage patients with heart failure preserved ejection fraction. So there is a shift now to look at the heart failure syndrome across all ejection fractions, not just the reduced ejection fractions as we did previously. And for CKD, it is also an epidemic. CKD is thought to affect nearly 10% of the global population. which is about 850 million people. Prevalence on the rise and has risen massively between 1919 and 2016. It's expected to reach about 17% by 2030. It is the third fastest growing cause of death, and it's the fifth most common cause of years of life lost by 2040. In the UK, it's also quite a challenge with high prevalence and the challenging element of CKD is that large proportion of patients are not diagnosed, they're not coded, and therefore they're not managed and monitored properly, and therefore the progression from chronic kidney disease to end-stage renal failure is more likely to happen. But also, of course, most people with CKD die from cardiovascular disease, as we will explore later on. And you can see that the use of replacement therapy, kidney replacement therapy of all types, is on the increase generally, and that's the most expensive and extensive in terms of burden on the economy. The interplay between these conditions is well established. So if you notice here, I've included diabetes because it has both contribution to both heart failure and CKD. As you can see, that about 40 to 50% of patients with heart failure have comorbid CKD as well. And that shows the interplay between the two. Common risk factors for heart failure, CKD, include obesity, inflammation, and vascular disease, and we'll elaborate on that. So there's a huge interplay. There is something called the cardiorenal syndrome, and that is a clinical condition which impacts both the heart and the kidneys, where one organ, be it kind of chronically or acutely impaired, leads to either the chronic or the acute dysregulation and impairment of another. And there are 5 types. You start with renal, with cardiac leading to renal in type 1 and type 2, and then you've got in type 3 and type 4 renal leading to cardiac dysfunction. An example of type 2 is a chronic heart failure leading to CKD, and an example of type 4, CKD leading to chronic heart failure. So heart failure can lead to CKD, and CKD can lead to heart failure because of this bidirectional link that exists between these two organs. And that's why they're very important and linked. By no means I am planning to detail this, but this is just explains some of the elements. So if somebody has got CKD, these are the things that are likely to lead to chronic heart failure. So patients with CKD end up with hypertension, which can lead to left ventricular hypertrophy and other dysfunctioning within the heart, and vice versa. When you've got heart failure, you've got increase of the renin-angiotensin system activation and the symptom and the sympathetic nervous system activation, which leads to vasoconstrictions and damage to the kidneys. And also there is more accumulation of fluid, which also leads to poor perfusion of the kidneys, leading to damage, so hyperperfusion, congestion. So heart failure can lead to CKD and vice versa, where you've got also CKD leading to heart failure because of similar activation of markers where they activate the renal angiotensin system, or you've got anemia or uremia, leading generally to more damage to the heart and remodeling and left ventricular hypertrophy and fibrosis, etc. So there is a strong link and interplay between the two, and that's why when we're managing these conditions, we need to be thinking that they are very, very interlinked. So just giving a quick snippet of what heart failure is. It's a complex syndrome, as I said. We no longer just talk about ejection fraction, but it does guide therapy generally. And it is basically when the heart's ability to maintain the circulation of blood is impaired due to various reasons, whether it is structural or functional impairment. And usually this is a burden that is in the UK. It is we see a huge number of patients impacted by about 1 million people with heart failure. It has heavy burden on hospitals, etc. The symptoms, we usually talk about the BEAT, which is the BEAT campaign is to say if you're feeling breathless, if you feel exhausted, if you've got ankle swelling, then think about seeing your GP and having a test done. The test is the NT-proBNP, which usually we use in order to start ruling out and thinking whether a patient should have their echo done to exclude any abnormality in the structure of the heart. So these are some of the symptoms and the signs. So this is the NICE diagnostic algorithm. As you can see, start from doing an NT-proBNP after somebody's got suspected to have heart failure, and then depending on the results, it would be decided whether they should have an echo within 2 weeks or 4 weeks, or can wait, or they don't need an echo urgently. So an echo is the gold standard that we use for diagnosis, of course. The ESC guidelines have slightly different cutoff points to the ones that NICE uses, but then it leads to differentiating 3 types of heart failure based on the ejection fraction. If it's 40% or less, if it is 41 to 49, if it's 50 and above, so you've got the HFrEF, the HFmrEF, and the HFpEF, and that's previously we used to focus mainly on the HFrEF. I don't want to dwell into NT-proBNP, but NT-proBNP it's a type of natriuretic peptide which is excreted to promote urine excretion, relax blood vessels, so trying to counteract the effects of heart failure. And therefore the body tried to do it by excreting the BNP or NT-proBNP. So these are the different types of heart failure that I've spoken about. Of course, in terms of causality, in terms of what leads and comorbidities, you can see that ischemic heart disease is one of the drivers of it, diabetes, hypertension, atrial fibrillation. So these are some of the causes of heart failure. So when you look at the risk factors related to different types of heart failure, which is HFrEF and HFpEF, there's some common risk factors, such as obesity, hypertension, type 2 diabetes, and kidney disease. And there are some kind of conditions we're more likely to drive one type of heart failure rather than the other. I've already mentioned about the renin-angiotensin system, the sympathetic nervous system activation, natriuretic peptide. I'm not going to repeat that. And that's pretty much kind of highlights where probably the medicines we prescribe are going to be targeting. We do use the New York Heart Association in order to distinguish between the different levels of symptoms that the patient's having with heart failure, where we look at the functional classification, basically, i.e. that the patient having heart failure to have any limitation in terms of their physical activity, or there's a slight limitation or marked, and they get classed according to their ability to function and do certain activities. How do we manage heart failure? Well, there's so many guidelines. I'm not going to dwell on all of them. This is literally snippets so that you're aware. You can go and search and look in more depth. But the NICE guidelines on heart failure are outdated. They came out in 2018. They're being reviewed. Probably the most up-to-date element out there at the moment for NICE is the NICE quality standards, which were published 2023. The American guidelines and the European Society of Cardiology guidelines are more up to date, and they're quite more relevant. So these are the American guidelines, and it's interesting. The American guidelines talk about how to prevent heart failure. So they talk about screening for patients who are at risk of heart failure, can you tackle it, people pre-heart failure, and then people who've got symptomatic heart failure. And they talk about every stage and how to manage it. So they say, for example, what should you be prescribing for people who've got diabetes in order to reduce the risk of developing heart failure? Because patients who have diabetes have high prevalence of heart failure, and therefore, for example, the prescribing of SGLT2 inhibitors for patients who've got diabetes seems to reduce their risk of developing heart failure as they progress. So this is kind of the way that American guidelines go. The quality standards got like 5 statements that you can have a look at it, but there's a focus on the therapy in statement number 3, and you can see that there are 5 pillars, if you like, that are focused on when we manage heart failure that I'll detail in a second. This is the European Society of Cardiology guidelines, talk about the 4 pillars of management, which is ACE inhibitors. They then jump to ARNI, which is an Entresto, which is a combined valsartan with an inhibitor of neprilysin as well, and beta blockers, MRAs, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. And the reason that these are called the main pillars is because they've got mortality and morbidity benefits. And then you've got other therapies such as the diuretics, which are used to control symptoms, but also not to forget the devices, the different devices, whether it is the cardiac resynchronization therapy or defibrillators or pacemakers, that also be considered there, and additional therapies depends on the comorbidities that the patient have. The American guidelines are similar, so the list is similar, and they go on step approach of what other therapies you can use. Again, it's beyond the scope of this talk to actually delve into these therapies, but these are mere highlights. Now, it's interesting, previously we didn't used to talk much about treating heart failure with mid-range ejection fraction or preserved ejection fraction, but now the ASC guidelines clearly say that you've got a patient with mid-range ejection fraction, that's somebody who's got more than 40% but less than 50%, then these are some of the options that you can use. Not as much robust evidence, but it's interesting that SGLT2 inhibitors are actually relevant to all types of heart failure at all ejection fractions, and diuretics, of course. So this kind of what is recommended in the ASC guidelines. The American guidelines are a little bit more generous, and they seem to think that you can use these therapies in reduced ejection fraction almost in all types of ejection fractions, except that they exclude the beta blockers from being included in the preserved ejection fraction element. So these are the 5 pillars, and the 5 pillars includes cardiac rehab as well. So you've got the ACE inhibitors, the ARBs, and the sacubitril valsartan, which is Entresto, the ARNIs, the 1 pillar, beta blockers, MRAs, SGLT2 inhibitors, and cardiac rehab as the main pillars managing heart failure. It is interesting that some of the therapies, such as SGLT2 inhibitors, are relevant to both heart failure and CKD, as we will be talking about it later on. So SGLT2 inhibitors in CKD, they reduce progression of CKD, but also they reduce cardiovascular outcomes, improve cardiovascular outcomes as well. Same applies, of course, for ACE inhibitors and ARBs. So ACE inhibitors and ARBs are recommended in heart failure and also are recommended in CKD as well. One of the things that has been happening is this is a trial called STRONG-HF, where basically it advocates the introduction of the 4 pillars as soon as possible and up titrating as soon as possible. So we moved away from the old way of managing heart failure where you start a drug at lowest dose, you take your time up titrating, then you move on to the next drug and you take your time up titrating. At the moment, because of the benefits seen in reducing mortality, in introducing all the 4 pillars, the current trend is to introduce as many as possible of all those medicines in order to reduce outcomes. And basically, the STRONG-HF trial was actually showing really good outcomes, and that's why it's very important to think about getting the patient on as many of the heart failure therapies as possible, then up titrating. And this is just data showing the difference in reduction in mortalities at 12 months post-diagnosis of heart failure. You see somebody who's not on any heart failure medicines, the risk of dying, all-cause mortality at 12 months, 36%. If you put them on an ACE inhibitor and a beta blocker, you're reducing that to 20%. If you put them on an ACE and you put them on an ARB or an ARB or an ARNI, beta blocker, MRA, and SGLT2 inhibitors, you're reducing the risk to 11%. So that's an absolute risk difference of about 25%, which is a massive difference. That's why time is important. The sooner you put people on those medicines, the less likely that they will die sooner, and therefore the advocacy of that. There's a newer drug which is now in the market, licensed for use in patients with kidney disease, called fenrenone. It is similar to spironolactone, but slightly different. It's a mineralocorticoid receptor antagonist, slightly different in its mode of action. It's licensed at the moment for use in patients with CKD, and there is evidence that it reduces the progression of CKD, but also improves outcomes and cardiovascular outcomes. But while doing the CKD trials, it was found to be also beneficial for heart failure. So at the moment, the thinking is that both SGLT2 inhibitors and phenrenone are seen more of a preventative drugs to prevent heart failure and developing in patient with diabetes and CKD. So both of them are becoming probably, I mean, SGLT has already got a license for use in heart failure, and phenrenone trials are showing that it's going to be beneficial in heart failure as well. It probably would be instead of spironolactone, not with. Slightly works differently. But the interesting thing is that both SGLT2 inhibitors and phenrenone are seen more of a protective. And there's also studies around semaglutide use, which is a GLP-1 agonist, and there was evidence of its benefit in heart failure with preserved ejection fraction. So there is also the use of that. And of course, iron supplementation is a big thing in heart failure. Because patients develop anemia and they've got poor absorption of iron, and therefore IV iron has a big attraction. As you can see here, there's a lot of trials in the pipeline about the use of phenrenone for heart failure and CKD. So there are more trials that are coming through, and there are more trials coming through from heart failure. The Fine Arts trial on heart failure has reported in ESC last year, and it was positive, showing benefit of the use of phenrenone in patients with mid-range and preserved ejection fraction. There's more coming. So this is another drug that is now becoming a drug for both CKD and heart failure, similar to SGLT2 inhibitors. We talked about iron supplements, mainly IV iron. GLP-1 agonists, the focus on their benefit in patients with preserved ejection fraction seems to be both related to obesity, but also independent of obesity. And that's why they're gaining more attraction for using for patients with heart failure. What is interesting is that data has come from FLOW trial showing that semaglutide is also seemed to be beneficial in reducing the progression of CKD as well. So independent of whether the patient is an SGLT2 inhibitor or not, if people are given semaglutide, independent of weight, it seems to slow down the eGFR decline as well. So we've got more in the pipeline. So there's no license yet for the use of GLP-1 agonists to reduce progression of CKD, but it is showing in clinical trials, and probably that is coming in the pipeline. To just dip in CKD quickly, conscious that the time is very tight. What is CKD, chronic kidney disease? Well, it is not an acute kidney disease. The chronic one is defined as an abnormality, whether it's in structure or functional, that's present for a minimum of 3 months. Therefore, whenever you do any check on eGFR or urine ACR, before you jump to diagnosing somebody to have a CKD, you need to repeat it 3 months apart. And only if it is seen to be persisting, somebody is given a CKD label. Now, CKD, in order to diagnose somebody with CKD, you need to think about it like blood pressure, where we have systolic and diastolic. You always need to have 2 readings. You need to have an eGFR reading and need to have a urine ACR reading. So somebody could have a perfect eGFR of more than 90, but if they have albuminuria, which is urine ACR, then they have CKD. So this is kind of the idea behind it. And of course, the lower the eGFR, the higher your risk of having cardiovascular disease and going into end-stage renal failure and having complications. And the same with albuminuria, except that the higher it is. So the higher the albuminuria, the more likely that you're going to have complications, the higher your cardiovascular risk. And what's interesting is that CKD is like hypertension. It is asymptomatic until very late stages. And you don't see usually any symptoms to start with. And the same thing with albuminuria. It can be completely asymptomatic. And that's why we need to screen and look for CKD in order to manage it as early as possible to prevent its progression. CKD is a target because it has a huge impact and relevance. It is a cause of a lot of premature death. And most people with CKD will die from cardiovascular disease. It's only very few patients in the context that end up having to have dialysis or transplant, though it's going to be so expensive. But the majority of people are more likely to die from cardiovascular disease. That's why it is important to identify appropriate and timely management in order to prevent the progression of CKD generally. You're going to have that. I mean, when you watch this screen again, you can have a look at the description here, but it's all tell you about how do we actually diagnose somebody with CKD. The idea is not to jump quickly to that label without checking and assuring. Patient with moderate to severe CKD, this is like what likely to see. If you've got 100 patients with moderate to severe CKD, 38 will have unplanned hospital admissions per year. There'll be probably 7 deaths per year. There'll be probably 2 ICU admissions per year and 6 cardiovascular events per year. So it's a cardiovascular risk. It's a strong risk factor for all CVD events, and it's more than diabetes. As you can see here, it actually increases your risk. This is the risk if you've got, for example, CKD and diabetes. What's your risk of having heart failure? You can see how many times it increases, and you can see for all the other cardiovascular complications. And this just gives you the same figures again. So you're talking about 4 to 14 times increase in the cardiovascular mortality as eGFR declines. The same with albuminuria. So even if you have normal eGFR, or your eGFR, for example, in this case is stage 3, the higher the albuminuria measured by urine ACR, the more the all-cause mortality, the higher the cardiovascular mortality, and the higher risk of end-stage renal failure. So urine ACR is quite significant. How do we manage CKD? Lifestyle modification, blood pressure control is vital. And the introduction of an ACE inhibitor or an ARB is quite vital as well. And of course, being on a statin to low cholesterol. And then after that, introducing SGLT2 inhibitor, phenrenone, and GLP-1 agonist, usually in the pipeline. So this is how we manage CKD generally. If somebody's got really high albuminuria, the focus usually is to better control their blood pressure and make sure they are an SGLT2 inhibitor. And the target of blood pressure could be made tighter if the albuminuria is higher, as NICE indicates in here. So if somebody's urine ACR is 70 milligrams millimole or higher, then you aim for a lower blood pressure target. Other guidelines seems to go for lower targets generally. This optimal care model offered for patients with CKD, depending on the severity of it. So you start from CVD, CV risk reduction, identifying patients at higher risk if they've got CKD. And then as you progress, you're talking about more intensifying therapy, promoting self-management. And of course, patients in CKD G5, they are people who are getting prepared to have kidney replacement therapy. For that reason, and because we don't want to end up in the kidney replacement therapy territory, and because many people end up dying from cardiovascular disease, we need to screen and find those patients as early as possible. So that's what NICE says about the people we should watch out for. People with diabetes, hypertension, we need to make sure that we do both. We measure their creatinine, but also we measure their urine ACR. And we're not good in measuring urine ACR. And we forget the importance of urine ACR when we're trying to diagnose CKD. And it is like when you measure blood pressure and you do systolic and you forget the diastolic. You can't do that. You need to have both. So we need to remember that. And this is when to refer. This is in the NICE guidelines. I don't have to dwell into it, but it's quite important to know when to refer to nephrology, because most of those patients don't need to be referred to nephrology, and they usually need to be picked up in primary care and managed there. The last thing is communicating, and Helena is going to cover this. Many people who've got CKD don't know that, and it is quite important to know how to communicate it and to communicate it with patients so that they appreciate what they have. So I'll stop here. I'll hand over to Helena. Thank you so much, and I hope that gave you a snippet with both heart failure and CKD.
Thank you, Ronnie. There aren't any questions in the chat, actually, so I'm going to move straight on and introduce Helena Gregory, who's one of the pharmacy and medicines leads in North Cumbria, and is an excellent speaker to talk about personalised care in this condition in particular. Okay, over to you, Helena.
Thank you. Hopefully the screen's sharing okay. Yeah, excellent. So hello, it's great to be with you. Thank you very much, Jane, for the introduction. And as Rani said, I'm going to try and pick up just as he left off talking a bit more about chronic kidney disease, how we can approach that and some of the interplay and cross-pollination in terms of the therapies. So we will be using Slido during the presentation. There's kind of 3 opportunities for you to contribute in. It's fantastic because it's anonymous, so nobody knows who's given the answers. So please, either on the device that you're on, navigate yourself to slido.com and put the number in there, or if you've got a separate mobile phone or tablet, then you can use that to point at the QR code and take yourself to it. And we'll be starting with that in just a couple of slides time, so do get yourselves ready to join. In terms of chronic kidney disease, we're going to very much look at it from a practical aspect, what you might be looking at in medication review and some of the advice that you might want to give. As Rani said, people quite often starting from a point of 0, so we have to take ourselves a step back. And acute kidney injury, very much the same with that, what we need to be thinking about when people are giving advice in advance of or during advanced kidney injury, and some of the multidisciplinary team that we might be working with, having a focus on the SGLT2 inhibitor in particular. So setting off with chronic kidney disease, as Rani said, in the early stages, there are often no symptoms. People might appear healthy and well. So it might be picked up, for example, in a blood test following a health check or another reason. So maybe they're starting an ACE inhibitor for hypertension or a statin for lipids, and we've done a test and we've gone, oh, something's not quite right here. And therefore, the discussion can sometimes be a little bit challenging because we're at that very early stage. We haven't got somebody coming in with symptoms. Equally, you might get somebody later on who's actually got a long list of comorbidities, a long list of medicines. Actually, they need quite a lot of adaptation, and we'll dive into what some of that might look like later on as we go for the conversation. But for the public, a lot of them will think of renal failure or chronic kidney disease. They might not even know what that term is and what that might mean for them. A lot of people will think about dialysis, but as Rani said, a lot of people are not going to get that far. It's probably the cardiovascular disease that's going to get them before that. And in this digital age as well, a lot of people will be using the NHS app. They might look on that, look at their problems, go, I've got chronic kidney disease. What on earth is that? Nobody's ever told me that. What does it actually mean for me? Again, even if they're at quite an early stage and it's just gone on there. And then we've got the opportunity to engage them in a conversation about risk factors. And last time we talked in our presentations about how to have that conversation on risk factors. So please do go back and have a look at it if you want to know how to have those conversations. So we need to meet people where they're at on the day, and we need to kind of understand what that is, first of all, for them, and think about the principles of how they might appear, some of the information that we've got on our clinical systems as well about comorbidities, medication, sort of the trend of their kidney function and their expectations as well of what it means. So we're going to dive right in with a Slido for you. So please navigate yourselves over to the Slido. There's the code again for you. And just your thoughts initially about where you're at. Let's see where the room is at. So Mrs. Smith has rung up. She's a bit worried because she's got chronic kidney disease on her NHS app after a health check. She feels fine. She's not on any other medicines at the moment. And her EGFR is about stage 3A in the middle there. We're not dramatically worried about her, but actually she's seen this. So what are our first thoughts for Mrs. Smith? What might we say to her? And we'll just give people a couple of minutes, just type in a few words. What are some of the words that you might use? Great. So we want to explain to her what are some of the words. Okay, so we want to get a repeat as Rani went through. Reassurance, good. Don't panic, yes. Let's take the temperature down a bit. We want to monitor her. We want to do prevention, really good. So, you know, we're looking out for her. We can do something about this. It's not the end of the world. And we'll just take another 10 seconds to put a few more words in. You can see what's coming up on screen from other people. I love the identify what she knows so far. How recent was it? Do we need to repeat? Empathy. I love that. A sense check and some empathy. That's the first thing that we want to do, is just like, yeah, I can see what's happened here. Okay, fantastic ideas there. Hopefully that's given the people some inspiration as to how we can have the conversations. And I just want, before we start, to kind of go through the process of medication review before we go on to look at how to have that conversation. So there's some really good information on the SPS website about how to have a medication review for people with kidney disease. And it's starting with the person. As quite a lot of you said, actually, we want to empathise with them. We want to find out what's important for them. We want to reassure them. So we're just doing that sort of softer stuff first with them before we're moving on, and then we're asking them what do they understand about kidney disease, what do they understand from what they've read. But a French study shows that when people are getting very few symptoms, people don't necessarily want to think or talk about it, and the prospect of future dialysis is actually really worrying for them. So we might have that kind of slight disconnect there before what we're doing. And when we're having those conversations, starting with the person, starting with what matters to you, tell me about yourself. What do you want to get out of today? And it can be a little bit tricky to swing ourselves around from just explaining and diving in with the advice to just taking that moment to kind of understand their position, because that will help us to develop our advice much more effectively as we go through. And this is all part of the team talk part of the 3-talk model. Again, we've covered that before in some of our previous webinars. So if you've not seen it, please do have a look back at the cardiovascular disease ones. But this is all part of the team talk to help to focus the conversation. You can check the patient's understanding before you launch into the options. It makes sure that you can pitch your language at the right level, keeping it simple, providing written information. Maybe they need a video, etc. Maybe we need to help them understand one little bit before we can kind of move on to what their choices are, and making sure that we've got all of that locked in. And what it says on the screen might be very different to their knowledge. So thinking about having a look at the information sources that we've got on the screen and thinking, how much of this do they get and what format and what language are they using, so that we can mirror their language. So this discussion can be really, really challenging, and using a kind of elicit what they know and then advising, elicit what they know. So in a dialogue, it's a two-way conversation and understanding at each stage how it lands. So chronic kidney disease, do they know what it is? Tell me about it. Actually, they're like, I don't know. I think it's people on dialysis. That's not me. I feel quite healthy. It's like, right, okay. So we might be able to describe to them, it's a long-term condition. The kidneys don't work as well as they should. And it's like, all right, that's okay, you know. And then it's, how does that actually land with you before we move on? Just that empathy moment again. So you might just kind of say to them that quick question, or you might be looking at their body language. Are they surprised? Are they still worried? Are they nervous? Do they just like, and so what? But the important bit is we can reassure people that they can live a long life, a good quality of life, and it's perfectly possible if we follow the lifestyle, the medication, and thinking about the risk factors that we've talked about. But that's all embedded in, so what? What does it mean to them? What is the hook for them? And we might have picked some of that up in our earlier team talk conversation. So actually, they might be a little bit worried about things. They might know, for example, if they're from Black or South Asian origin, that they're more likely to be affected and be like, my uncle's got that. I've seen what happens. I really don't want that to happen to me. You know, that's something that you cannot change. You cannot change your background in that way. You cannot change your age, but there are some things that you can do, and you can reassure them that there are things that they can change to make a difference. But that last bit, that now what, is really, really individual. So you've got to do that eliciting from the first part of their understanding to understand how to pitch it, and also having some resources at your fingertips, so that if this is something you do every day, fantastic. If it's not, it's actually thinking, how do I refresh my knowledge? And there's some fantastic advice that's out there and available. So first of all, the BNF, absolutely brilliant for medication, and it's a really good refresher if you want a little bit of CPD and you want a little bit of, I won't call it bedtime reading, but background reading, just to refresh your knowledge on medicines and renal function. But it also reminds us of the complexities of kidney function, the different parts of the kidneys and how everything moves through them differently. So we'll all have had a background as healthcare professionals in the structure and function of the kidneys. Some people, you know, if you've done sort of pharmacy or pharmaceuticals, you might know a little bit more about how medicines are metabolized and all the different factors that affect that. But equally, you've also got a list of the nephrotoxic medicines in there, and those to be really cautious. From avoid completely to actually you can use this, but just monitor really carefully. If you want to know more about a particular medicine that you're coming across regularly, then the summary of product characteristics have a lot more detail. It's always under the special warning and precautions for use section and includes notes on renal function. So that might be of particular interest to you if you've got a specific scenario and you want to know exactly what is happening, what that interaction is. So for example, for ibuprofen, we might be talking about retention of electrolytes, the renal toxicity reactions, both of which, if we're thinking about somebody with heart failure, it's common sense, but actually we're thinking this would adversely affect somebody with heart failure. So it's just kind of getting that kind of cross-pollination going. To bring it to the more practical, we've got the Prescript advice pack. So this has got wider advice on management, some of the things that Varney's gone through about that early identification and stratification, monitoring. And here we start to see the crossover with cardiovascular disease. So it covers things like statins, blood pressure, antiplatelets, and other cardiovascular medicines, and just gives you, again, a few bits and pieces and tidbits that you can use in your conversations in practice. And then there's also a primary care pack from Kidney Care, which is absolutely brilliant. So there's loads of statistics, risks and benefits of things, you know, as some of those that Varney's gone through there, if you want something to refer back to. And there's also practical advice on how to talk to patients and some of the things that you can use. So I would recommend a bit of a look at that one as well. And then thinking about how the integration with other conditions is really important. NICE CKS is a really good place to start looking at this. Lots of medicines can be used for more than one condition within the cardiorenal metabolic space. So taking a person with heart failure and CKD, there's a good chance that they could be on all of these. Again, as Rani said, we might have people on there. And so we've got to consult multiple guidelines to handle them. But the good thing is this is where we bring them together rather than looking at them in the silos as we've more traditionally done. You can have a look as well if you want to know more about heart failure in our palliative care session that we did last time. So there's quite a bit more information there about end stage heart failure and how we might be looking at that with the comorbidities. So please do have a look at our palliative care session if you want to know more about the heart failure. So we've all heard of Dr. Google. We all know our patients like to Dr. Google. Well, the bad news is that our patients who are coming through now for our hypertension and health checks, they're in the 40s, they're millennials, they're not our older folks anymore. So actually they're starting to look at information in a new way. So does anyone know, can anyone put in the chat what the fastest growing search engine for Gen Z and millennials is? So that's people from the 20s up to their 40s. What are people looking at? Let's have a look. What's the fastest growing search engine amongst millennials and Gen Zs? 2/3 of Gen Zs and half of millennials use it. Oh, someone must know. TikTok. Oh, well done to Simi. Well done, Simi. Fastest finger first there. Yeah, it is absolutely TikTok. And it's really important for us to signpost to reliable sources, because if we don't, this is what you're going to get. I thought yesterday when I was planning this, I would have a look and see what was actually on TikTok if I typed in chronic kidney disease. So good news is, first thing is Dr. Amir Khan. We like Dr. Khan. Fantastic. He's very sensible. Fortunate. That was number one. Really happy. I only had to scroll down one page to number 7 before I came across this chap who was selling some supplements and 3 top supplements for your kidneys. And you can see we're already out of evidence-based medicine and potentially into something very different. And that's what our patients are going to be doing if we don't give them the right information. So what are the alternatives? Well, for people who prefer written materials, we've got the NHS website. It's got very simple language. That's what I used before for the descriptor. It works for any level. but it is written, so there's no videos on there, etc. But you can also have a look at Kidney Care UK. So they've got leaflets, they've got videos, which are very popular, as we've said, for younger people, and good infographics to explain what the kidneys do if you want to have that conversation and introduce interdependencies such as hypertension. So if you've got any other favourites, please do add them in the chat as we go. But that's some of the examples that we've got there that you can have a look at, and you can share with your patients if they're wanting to have a look. So SGLT2s, as Rani was talking about, the unpronounceable gliflozins, these were originally used for diabetes. And as Rani has said, they're now recognised and used widely for heart failure, for chronic kidney disease, and work by blocking the reabsorption of glucose in the kidneys. So they increase the amount that leaves the body in the urine, helping to lower your blood glucose levels, reducing your blood pressure, reducing weight, and many other benefits there. So it's kind of a fantastic new medicine, bit of a one size fits all. But there are risks and there are benefits. So it's a really beneficial medicine, but there are a lot of safety considerations as well that we're just going to go through briefly today. But again, if you're following that team talk model, you've had that conversation about chronic kidney disease, you've had that conversation about where the patient's at with it, that's your team talk done. You're now moving into your choices, and SGLT2s will come in as part of the option talk and how you support them with making the treatment decision of what are they going to do going forward. So what are the risks and benefits of SGLT2s? There's some information here which is taken from the previous diabetes therapy paper that was labelled. It goes from the generic information at the top. So we might be having a look at this at a very high level and saying we've got real value from this. We're reducing deaths, we're reducing disability. It works for a very wide range of individuals, very wide range of risk factors, from early disease through to, later stage heart disease, for example, very well tolerated, through to much more specific things. I haven't put absolutely everything in, but there are a lot more examples we'll have a look at later, through to actually standard care versus adding in an SGLT2 to that. We're reducing the primary outcome of risk of worsening heart failure and hospitalisation and cardiovascular death by 26%. Fantastic. So that might take it from, if you've got 4 people who are affected by that within your risk group, actually now we're suddenly down to 3. And actually that can make a real difference to somebody. But equally, it is a really good drug, clears out a lot of glucose, but we do need to be open with people before they choose it and whether it's right for them around the safety considerations. And again, a lot of this is very personal, and you might cover some of it in your team talk. So there is a risk of diabetic ketoacidosis for people. Again, if they've got diabetes and renal failure, then we might be having a look at the two together. But if they're following a very low carbohydrate diet or a ketogenic diet, then we've got an additional risk there. So actually understanding those person-centered risks are really important. If they've got any foot disease, risk of lower limb amputation, that might be slightly different to this. Perhaps they've had a foot injury or something in the past, or again, perhaps they're diabetic and things are not going so well for them. Then again, we might want to be really cautious. And also thinking about complicated and frequent urinary tract infections. And that's not even necessarily older people, but you might be having younger women who are coming in as well, who find themselves in that scenario. So it's setting up those thoughts initially to people of what do we need to be cautious with, but also you might be setting out some deprescribing expectations at the outset. So for example, if your kidney disease continues and progresses too far, then you might need to stop if your EGFR drops below a certain value. So saying this now makes it a little bit easier to have the conversation, to review and stop it down the line. So this is actually you being kind to your future self, just saying, actually, we need to be looking at this here, and we'll be monitoring you regularly. Some of you said that earlier, that that careful kind of monitor and review is really important. But actually, if you've on heart failure, then we've mentioned that it can increase the amount of glucose in the urine, can increase the frequency of urination, particularly the first few days. So if they're on a diuretic, then you've got an additive effect straight away there, and they might need a bit of expectation for those first few days, and do a little bit of trial and error as well as to how it's going to affect them. So there's a lot of information I've thrown at you there. So you'll just need to weigh it all up. There are a couple of options for that. So the BMJ has some fantastic sections, having a look at the risk of progression, the benefits, the harms, the practicalities, the preferences in that. So things like pill burden and monitoring will be really important to them, number of appointments, and thinking about it. And you can give them some patient information to take away as well, which puts it much more simply. So again, this is from Kidney Care UK. Do have a look at that, and you could perhaps text them a link or print it out for them. You don't have to do all this in one conversation. That can be really hard in 10 minutes. So the first bit might be the 10 minutes, and then actually we've given you the information, and then we're going to come back to talk about your options later on. So another quick question for you on the Slido before we move on to acute kidney injury. How would you share the benefits and risks of SGLT2 inhibitor treatment in practice? I'm sure you have a much more patient-friendly way of doing it. The examples that I've given you there are obviously focused towards healthcare professionals, and the percentages and so on are focused towards healthcare professionals. I've just seen Patricia's question in the chat about video references. I found it really poor. I'm going to be honest. There was one which was on the Kidney Care website, which I think was originally from London. But if anybody knows of any other reputable sources, please do share them, because I found video information really poor, Patricia. So it's not just you. You're not looking in the wrong places. Okay, so we're starting to get a few things that are coming through. So the benefits outweighing the risks, and the BMJ one is really helpful for that. It shows you which side of the line it kind of sits. Written on paper, yeah. So we might print out the kidney care information to share with them. Using easy vocabulary, that's good. Graphic chart, oh, that would be good. If that person wants to share a link to that in the chat, it'd be really good to see. Knowing about the patient and their lifestyle, yeah. If you've done your team talk well, or you know them, perhaps they're coming in to see you every 3 to 6 months for a review as part of your clinic, and actually you know them quite well, and you can gauge and focus that a little bit better. Okay, I think we've got a couple more. We'll just give it another 10 seconds to pop that in before we move on. Go. The reducing the mortality. Yeah, if that's something that's really important to them, and back it up with advice they can take away later. Fantastic. Okay, so let's move on to acute kidney injury. So you might be talking about this and the risk of prevention in a clinic, such as initiation of a medication, reinforcing structured medication review, or actually someone might be attending your clinic unwell and they need advice and signposting, or you might be following up, and that's much more common than you think. So about 13 to 18% of people admitted to hospital are affected by AKI. That's where your kidneys suddenly stop working properly. It can be from a minor loss through to complete kidney failure, and it's usually as a complication of another serious illness. So we need to make sure that we're treating people well before those levels build up, which can then affect the ability of other organs to work properly. Again, if you've already got problems such as heart failure, it can be really difficult. So it's overrepresented in hospital admissions, and particularly in that last year of life. Again, have a look back at our palliative care presentation to think about how you might have some of these conversations with people in that last year of life, and we'll focus now on the healthy and well. So this can be a tricky one to approach. So if you're talking prevention with someone at risk, or as I say, they might have come in unwell, and it's back to that illicit advice, illicit dialogue with them, understanding how it lands with them, having a look at the body language, thinking about additional information. So do they need sick day advice? How might this affect them? Do they have acute illness? Do they come in regularly vomiting or regular UTIs? Are they at higher risk because of heart failure or chronic kidney disease already? What's the baseline? Are they already trending down quite quickly? So we can take that what and so what approach just to, you know, gauge their level of understanding, but the now what is really, really individual. And quite often we're taught about the sick day rules, that when we're unwell and we're taking any of these listed medicines, which by the way is ever growing. So it's gone from, I think, damn drugs to SADMAN. Now it's SADMANs because we've got SGLT2 inhibitors on the bottom. So actually having those conversations can be really difficult. We raise awareness during medication initiation and reviews. People generally don't take it in, and a small study demonstrated a lack of awareness. So it's not straightforward. In terms of the different medicines, there are lots of different effects. So for NSAIDs, which is perhaps one of the most common ones that we recognise, that's impairing urinal autoregulation, inhibiting the prostaglandin-mediated vasodilation, increasing the risk of AKI. Looking at blood pressure, again, we've got different types. So we've got our ACE inhibitors and our ARBs in that. Also looking at our diuretics. Again, if we've got someone on heart failure, they're probably on all of those. Our SGLT2s and diabetic ketoacidosis risk, again, could well be on that one. So we've actually got quite a multitude of conversations that we might to be having with this. So my last question for you here, let's just type in because I'm just aware we're hitting our last 5 minutes, is what are the factors that you take into consideration when you're advising your patient on sick day rules? What kinds of things would we be considering? So we've got our patient, they're on an SGLT2 inhibitor, they've got CKD, just wanting to make sure they know what to do. What are the factors that we're going to take into consideration? Okay, so we've got the responses starting to come in there. Okay, so the withhold, yeah, I'm going to come on to the withhold in a moment. Yeah. Understanding of what the medicines are for, that's really helpful. That is actually really helpful because that helps people to kind of work through why they're doing what we're asking them to do, giving some written backup information, indication, yeah. And we'll just have another 10 seconds before we finish up. There we go. Understanding the reasons, seeking further advice. Absolutely. And yeah, things we can do such as hydration, being aware, vomiting, diarrhea, dehydration, who to contact. Absolutely vital. So the risk from sick day rules can sometimes be greater than the risk of AKI, and sometimes you might need to use a professional judgment. So considering how vital the medicine is and what it's used for, so lisinopril, simple, stable monotherapy for hypertension, or an SGLT2 simple monotherapy for diabetes versus we've got lisinopril, double diuretics and SGLT2 inhibitor for someone with late stage heart failure. And actually, if we gave them the advice to stop all of that, the heart failure is going to take over and it could be catastrophic and land them in hospital. So we could then end up with decompensated heart failure because the VAS system and the diuretic drugs are discontinued, or we could have acute kidney injury caused by the right-sided congestion complicating the withdrawal of diuretics, or we could have development of poorly controlled hypertension because we've stopped that when levels were very high. People might overinterpret the advice and just stop everything even when they're not very well, or you know, they might not restart it. So we really need to think about vulnerable people with medical and social factors. Do they know who to contact? That might be primary care in a more simple case. It might be a nurse specialist or other person in hospital in a more complicated case. How do we make sure they're flagged so that they're prioritised? Can they swallow? Can they keep things down if they're being sick? We might have real issues there and need to switch to a liquid or to an IV. And some decisions are easier to make in primary care. So that monotherapy that I've talked about, you can probably do that in advance, but actually later on, then you might have issues that you need specialists. So how do we make sure that people know who to speak to? There is some information on Prescript. There's a comprehensive pack that's available, so please do seek out the sample patient information that's there. You can amend this to suit those more complex conversations, so please do have a look at them. And just to finish up, for SGLT2s, a person might be more at risk, as we've mentioned, because of the risks of diabetic ketoacidosis, urinary tract infections with the glucose in the urine, especially if it's alongside diuretics. So we need to think monotherapy, you're probably better to stop, black and white advice, later stage heart failure, stopping this and the diuretic could have catastrophic effects. So consider the patient effects. Do they have a UTI? That's actually precipitating this? Could they stop the SGLT2 that will help that UTI resolve? Can we titrate that down and actually keep the diuretic running, or titrate down the diuretic, and reviewing and restarting afterwards? There's some fantastic advice on NICE CKS for diabetes around kidney function. So make sure that you're having a look at that and your kidney function post AKI before you are restarting, and review and restart around 48 hours after the systems have improved. So think about your medicine factors, think about your patient factors, make sure you do that post AKI review and reinforcement of the advice. So that's a quick whiz through of CKD and AKI. I will stop it there and thank you very much.
Thank you, Helena. We're bang on 1 o'clock, but I'm going to ask you just to answer one question that's in the chat, because it follows on from what you've been saying, asking if UTIs tend to occur in those patients who are more predisposed to UTIs, if that's correct.
I'm not sure about that. I would imagine there will be some factors that will make people, so females, for example, because we have that sort of shorter urethra than the males, we are more predisposed to those. And again, age, because you've got that kind of asymptomatic bacteria when you're older that can quite quickly tip over. So there are some factors, but I don't know if Rani can add to that.
I think there's some newer data coming from trials showing that probably it is more the yeast infection that is more likely to happen with SGLT2s in genital area than the bacterial infections. So when you pull all the studies of the report of infections that patients been having, it was more yeast infection than actually bacterial infections, and therefore some argue that probably there isn't significant increase of urinary tract infection as in bacterial infections in those patients with GLT2s. This is kind of an opinion that is been supported a lot by the cardiologist at the moment, with based on kind of pooling all the data from the trials of side effects, and that most of the reports were yeast infection, and that genital hygiene is likely to reduce that. Saying that, I had 1 or 2 patients who did have UTIs, but it wasn't a trend, I have to say. It was some cases generally. That seems to be the thinking at the moment.
So a bit of watch this space, but it may not be quite as straightforward. Thank you both of you for excellent talks. You really do work together extremely well. So thank you very much indeed. Just a reminder for people that the next webinar is on the 24th of April on obesity, fatty liver disease and diabetes. So please, you'll be getting a link to register for that if you haven't already done so. So thank you all very much, and thank you for your participation. Goodbye.